some time for facilitated discussion later as well. Uh, Welcome, Kuyash.
Thanks, Farhan. Hi, everyone. Ben and I were talking about how it would be good for us once in a while to make quick announcements from our respective organizations. And so Ben is sending his regrets. He had some family emergencies and not able to join. And I would like to start us off with just quick announcements and also share some of the priorities that USAID is engaged. Um, I wanted to see if we can bring the slides or go to the next slide, please. Great. Couple of quick announcements. And first of all, I'm delighted to announce that Shami De Silva is the new director of PRH. And as many of you know, Shami has been acting in this capacity for several months when Alan Starboard retired at the end of last year. And as many of you know, Shami has worked as PRH Deputy Director and OHA Division Chief. And she first joined Global Health Bureau, by the way, in 2000 as a private sector advisor. And she, as many of us, worked as a private sector advisor and supported missions with private sector programming. She helped design and evaluate social marketing, social franchising, and other private sector programs. And she's also been a big supporter in rolling out the application of market development approaches for family planning. And so we are delighted and look forward working with her under her in her new role. And as she settles in this new role, we will see if we can ask her to join one of our future sessions for an informal chat. And so please have your questions ready. Um,
Welcome to
I
HSBC Advance. مرحبا بك في HSBC Advance. للاستمرار باللغة العربية اضغط 1.
All right, that's not me, but thank you for muting yourself. The next quick announcement is around the website that FHM Engage is helping us to develop. We may have mentioned this in one of the previous sessions, but just wanted to remind everyone that we are in the process of developing a project agnostic website to serve as a home for health market development resources and tools. USA envisions that this website will serve as a platform to share lessons and exchange ideas on implementation of local health market development approaches. The site will be called Health Market Links, and as soon as we have it ready, we will be inviting you guys to join in. This will be part of the USAID's Links family of 9 agency-supported websites, and I'm gonna paste some of them here if you want to check them out. And Health Market Links will house a robust resource library that will include Shops Pluses and other private sector projects, 2 decades of resources. And we also hope that it will become a go-to space for health market development experts and practitioners so that we can share our knowledge, make new connections, and also help evolve the dialogue around health market development approaches as related to family planning, but also broader health. So please stay tuned, and we count on your contributions to make it a successful website. And lastly, just wanted to bring everyone's attention to the private sector research priorities, which this group put together a couple of years ago. We have the slide deck that Elizabeth will share with everyone, but just wanted to let everybody know that we are using these research priorities as an important tool at PRH to inform our research agenda. And so please share if you are planning or doing any research that addresses any of these questions. And we also welcome your feedback on the utility of this tool. And if you have any other thoughts that you would like to share with us, please do so. And you can share your thoughts and by sending an email to me or to Andrea. I think we're going to the slide on next slide, please. And there are a couple of USAID level 3, actual USAID level initiatives and priorities that I wanted to touch base today. As you guys all know, USAID is leading efforts to operationalize PSE, private sector engagement policy. And as part of that, there is a PSE modernized efforts, which USAID is using to scale and mainstream its private sector engagement across the agency. And so it's an internal reform initiative which was launched last year in November, and it looks internally at our institutional conditions and operating infrastructure, and it aims to create capacity necessary to scale up the engagement and also investments needed to engage private sector more broadly. There is a link to the PSE Modernize. It's still a policy under development, but there is some limited information that's available online, and the link is on this slide. So please visit, and if you have any questions, reach out to me. But also, if you have any examples that you would like to share, country cases, please do so. I'll be more than happy to forward them to the PSE Hub for inclusion as they develop our internal tools. Next slide, please. You may have heard about the H Fund, and so we just wanted to take a few minutes to let you know that it's currently up and running. This is an internal incentive fund, and so either missions or some of the USAID operating units will be submitting proposals. In order to do so, we will need to identify private sector entities in order to suggest the partnerships that are catalytic, partnerships that this H Fund is excited and willing to fund. It's a $50 million fund, and it's looking for groundbreaking partnerships with the private sector. There is more information online, so please visit and let us know if you have ideas, if you have any questions. And on the next slide, there are some crucial information in terms of eligibility. Elizabeth, if you can go to the next slide. On the left, you will see a different type of private sector entities that are considered eligible for collaboration. And on the right side, you will see some of the requirements that the fund is seeking from the proposal. So again, there is a link to the H Fund. Have a look. If you have ideas, if you have private sector entities that you would like us to consider, reach out. We don't have a lot of time, unfortunately. The deadline is next week, but regardless, feel free to contact me and let me know if you have any thoughts. I'll be happy to answer questions as well. Next slide, please. And lastly, just wanted to let everybody know about the, just to remind you guys about USAID's priority around localization. This is an important priority, and we're looking at internal, again, reforms, actions in order to ensure that we are putting our local actors in the lead with transferring local systems and being responsive to local communities. Next slide, please. I think this is these are just some of the key areas that localization effort is currently working on, and we're going to also share with you a link to the USAID's localization website. Please feel free to visit and let us know if you have any questions. Also share your experiences. I think this is an important community where we are making sure that we are bringing country perspective. We are always having, we're always looking for local private sector, local market development approaches. If you already have some examples, if you have country cases, or if you have questions, do let us know. We'll be more than happy to engage you as USAID engages in the localization efforts. I believe that's my last slide, and feel free to come off mute and ask me questions, or you can also type them in the chat. I'll be happy to answer if you have any questions. Thank you, and Farhan, over to you.
Thanks a lot for that, Kuyosh. Yes, so as mentioned, are there any questions? Feel free to, either type them in the chat or please come off mute to ask or raise your hand. Any questions? So Kuyosh, I see one question here from Dan Rosen from Maisha Meds. He asked, as a private entity, they would be interested to understand how to engage with the Edge fund. Kuyash, I know you've provided some detail on that and there's a link. So these slides will be shared along with, when we send out the summary, of this session today and the recording. So these slides will be there. And so you will be able to access the links on the slides. But Kuyash, do you want to add anything else? It seems there are more questions on the Edge Fund. Are these funds available for implementation or research partners?
Maybe I can start with a question from Dan. And this is a new initiative, and we're still learning on the go. But from what I understand, Dan, I think the private sector, if you fall within one of those categories, you can submit your interest, and you will see a link in the Edge website where you can submit your very brief statement of interest. You can also reach out to any of us. We are happy to facilitate and help get you answers to your questions and help you determine whether you can partner with one of the operating units at the global level or with missions. And so let me know once you get a chance to look at the Edge website if you have questions, and feel free to shoot me an email. I'll be happy to either answer your questions or put you in touch with the right people. As for the second question, in terms of whether these funds for implementation or research, I believe these are for enterprise development. In our case, health enterprise development. And so it's really difficult to say for sure whether they can be used for implementation or research partners, but the fund did mention that this is not for something that USAID does traditionally, for activities that missions and the implementing partners usually have access to the development funds. And so, Soumya, I'm happy to discuss this further if you can give me a little more specifics, and we can take this offline, or you can shoot me an email, and if I don't have answers, I'll be happy to look it up for you.
Okay, thank you for that, Kuyosh. I do know we still have, some more time for this section of today's session. So are there any other questions? Okay, there being none, I think we can move on. Thank you, Kuyosh. Okay, so as I mentioned earlier, that was the first part of our session today. In the second part, we are going to continue. There was a lot of, interest the last time when we had our session specific to Tanzania. There were some, thoughts within the chat, and it seemed like there was eagerness to delve deeper into some of the things. And so what we did as a team is that we identified some of those themes and reached out to the people who brought up those themes so that we can, take those discussions further. We have identified, 4 thematic areas that we will go through as far as this discussion is concerned. Again, there was no obligation to have a slide deck. What we really want is for, people who brought up those thought processes to be able to share if there's been any, evolution in their thought process, if there's something they want to speak about a little bit more. So we have, reached out to 4 individuals who will speak to these thematic areas. To start off, our first discussion is going to be on the thematic area of data, right? We do know that, data, private sector data usage, how we are using data for decision making, what can the data tell us? These are all things that, we are constantly thinking about in our work that we do. And so we felt that the first area to discuss would be data, and particularly perhaps thinking about private sector data usage for decision making to improve family planning. We do have other speakers. I think I'll introduce them when we come to those parts, but we can go on to Dan submitted a presentation. So we do have a presentation from him. Dan, over to you.
Thanks so much, Farhan. Really appreciate the opportunity. If we could go to, I think, 2 slides ahead. Yeah, skip over this one. So the question that I asked towards the end of the last community of practice call was, why does the sales data from over 400 private facilities in Tanzania look so different to the results from the DHS survey? So in the last month or so, I've spent a bit of time digging into some of these questions and trying to answer that. I have some ideas. I am opening this up for a conversation as well, but I'm just going to kind of run you through a little bit of how I've been thinking about it and trying to explain some of the differences here. If we could go to the next slide. So the first thing to note is that Maisha Meds data is sales data. It's packs being sold by facilities. It's not in couples' year of protection. So when you convert from number of sales into CYPs, you get this graph here on the left. So the 35,000 women accessing hormonal contraception through our network in the last year. When you normalize that into CYPs, the graph starts looking maybe a little bit less shocking and scary in terms of the breakdown of the types of products that are being sold. And then the second piece is really like when we think about how might the methodologies vary between a DHS survey and collecting sales data from facilities. And the other thing is you've got a lot of subnational variation. So when we look at something like Masoma, where you've got a very high number of DMPA sales, this is sales, not CYPs, the chart on the right. So here you've got like a much higher use of DMPA intramuscular. So it's possible that our sample is a little bit more biased towards Dar es Salaam. It's also biased a bit more towards Mwanza. Now, I think Mwanza is really interesting because Mwanza and sort of that area around Mwanza is highlighted as having quite low uptake of modern contraceptive methods. But when we look at the sales in the facilities, we're seeing quite high sales of emergency contraception. So it's possible that if EC has not traditionally been captured as a method, that you actually could have a situation whereby it's being used instead of a lot of modern contraceptive methods. So certainly kind of digging more deeply into how these subnational trends overlap with access to modern contraception and some of the things highlighted by previous research, I think could actually be really interesting. If we could go to the next slide. Second point that I was going to bring up is that this really high use of EC in the private sector is really not exclusive to Tanzania. We are seeing this across sub-Saharan Africa, across the 1,700 facilities where we're working currently. we're seeing it accounting for 54% of sales in Kenya, 71% in Uganda, 79% in Nigeria. Admittedly, our sample in Nigeria is still pretty small at the moment. So what we're finding when we look at the private sector is that, you know, in many ways, it's kind of become the emergency contraceptive sector for family planning. There are other methods being offered, but there's actually not a huge amount of choice going on. The N is on the the N here is sales. Yes, that's correct. So this is not converted into CYPs. I apologize. I could have done that. I can do it, but so this is not really a Tanzania problem. This is a private sector choice and provider incentive problem. In Kenya and Uganda, Maisha has been running some programs to increase the uptake of Cyanopress, DMPA subcutaneous. The graphs here might look a little bit different. This is not completely, this is not just the behavior of facilities in the wild, as it were, because we have been intervening in these facilities to change behavior. So, you know, there's going to be some element here where the sample has been affected by the programs that we're running. The other thing that was really interesting is that we really are seeing almost no IUDs or implants. So, you know, really the facilities that we're working with tend to be like poorer, peri-urban, rural pharmacies, clinics, ADOs. We don't cover private hospitals. We're not doing large urban facilities where there might be more choices available. So I think our sample kind of leans a little bit more peri-urban rural. And that might be why we don't see a lot of private sector utilization of IUDs or implants. I think there are a few sales, you know, in the tens for different countries, but you know, it hasn't really been included in these graphs. If we could go to the next slide. So why might DHS miss this trend? So these are my theories as to why EC and levonorgestrel 1.5 milligram has not really been picked up as much. If we go back to slide 17, the graphs on slide 17 for the DHS results. So historically, EC has not been included as a contraceptive method in DHS or MICS surveys. Inclusions happened reasonably recently. Whether or not survey collection tools have been adjusted is sort of, I don't know the answer to that question. When included in surveys, it's often counted as a secondary method to other methods, such that if a household used two methods, it might not be included. There also may be some bias during data collection against inclusion for social factors, particularly associated with reporting infrequent intercourse, and we find that it's predominantly younger women accessing this method. So it's possible that there's some interplay there on the data collection. Literature reviews on the use of emergency contraception tend to show that existing surveys have had quite small sample sizes historically, been a little bit inconsistent in terms of the results, but generally there's some sort of a upward trend. Please don't, as you can see in the graph on the right, this is not exactly like a conclusive set of evidence, I would say, in terms of the uptake of emergency contraception usage. Lastly, the data is sort of extrapolated from a sample of women to total consumption, and there is a scale-up happening from survey to national data. And this relies on having a representative, unbiased sample, but importantly on having a suitable scaling factor. So being able to scale the utilization up from the number of packs that you're capturing to a national. So I think that there is a possibility that some of these assumptions may not be as well understood for emergency contraception as we see for other. I'm happy to take questions.
Okay, thank you for that.
Sorry, I think there's one more slide.
Yes.
Sorry. So Maisha Meds has been hired by the Gates Foundation to do a deep dive using a variety of private sector data sources to try and understand what the current market for levonorgestrel 1.5 milligram looks like across sub-Saharan Africa. This is ahead of the launch of Plan A, the pericoital LNG 1.5. So this hasn't been signed off just yet. So I don't want to say that we will be doing this, but with hopefully pending contract signature from the Gates Foundation, we will be doing a market sizing for this contraceptive method across the region. Focus is more on Tanzania, Nigeria, Kenya, Ghana, and Uganda. We're not just going to be using our point of sale data. We are going to also be using a number of other data sets, import-export data, and other available data sets. So yeah, the graph on the right is taken from the 2018 commodity gap analysis. And this is sort of an interpretation of how the world looks across sub-Saharan Africa for accessing or for the sources of revenue of money for paying for contraceptives. I have added the yellow bar, which is sort of my back of an envelope estimation at the moment of the amount of money spent on EC across the region. But it comes to about 48% of private sector spend. So that is a little bit about some of the work that we've been doing and some of the things that we've been finding. I'd be very interested in getting comments and input. I see there's some questions.
Okay, thanks a lot for that, then very interesting insights as far as, data is concerned. So I think just to reiterate sort of a disclaimer that, the analysis that was presented last week is based on, preliminary DHS results. We are still waiting for the final report and for the complete data set to be released. We are hoping that will be sometime in April. So, some of these questions and, might be answered. We might be able to see some similar trends as well. That is number one. I think number two, then there's always and I wonder what the thoughts of people in the group are about this, in that, whenever we have conversations around data, there's always, the fact that something like DHS is a point in time, right? Whereas something that, whereas Maisha Meds is really giving you real-time data. So there's probably, some value to that particular aspect as well. And, it would be nice to hear some thoughts in the group about that as well. As far as the questions in the chat go, I think some have been responded to. Yeah, then I don't know if there's any question that you want to respond to from the chat.
There's a really interesting conversation happening in the chat, and a lot of additional points. They're not so much questions as they are statements and additional information really coming into the discussion. I would be very happy to follow up on anyone who wants to talk about this a little bit more. I'm happy also to hand over to the group as well. Denise,
so then, yes, that's the one I was also looking at.
Yes, so we do capture data on manufacturer and brand. So I can dig into that. So for every sale that's captured by the platform, we see the price that they bought it from the wholesaler, the price that they sold it to the patient, the brand, the strength, the pack size, the form, so whether it's injectable, tablet, vials, things like that. So that's what's captured in the data that we can dig into. There's some really interesting things for me to follow up on here. Okay, thank you all so much for your time.
Thank you for that, Dan. And I mean, I see the interest in terms of emergency contraceptives. I think even from the work that we are doing in Tanzania, we are seeing, and it's interesting because when we look at the data, of course, even if it is or even some of the anecdotal discussions that we are having, it seems that especially from the private sector, there is a lot of ECUs, but then the discussion in country, and I think one of the things that we are trying to work on, even as FHM engages, how do we change the narrative from it? Because I think, the term emergency contraceptive, and I would love to hear thoughts from the group as well about that, is one of the things that we keep hearing, especially from some of the public sector stakeholders, is that if it is emergency, then does frequent use make it abuse? Like there's this whole discussion around abuse of emergency contraceptives, whereas it is something that is meant to be used. So I think the conversations that we are having currently is how do we change that narrative to perhaps calling them on demand contraceptives and not just emergency, because that term is leading to some sort of misunderstanding, some sort of stigma with regards to use and all of that. So I think there's always very interesting discussions happening around emergency contraceptives.
If I can just add to that, Farhan, I think
Yes,
that
Dan.
so the one of the things that we do see in our data is that 1 in 8 women are buying more than one pack of EC in one go, which would suggest that it's not being used purely as an emergency, but the women are buying them with the presumptive use of planning to use it again in the future.
Well, then, I mean, that's one way of looking at it. I think another way could be, are they also buying it for their friends, right? Is it that one person is going and, buying it, which is something that might be especially a youth behavior, whereas, not everyone wants to go and get it. Perhaps one person goes and gets it for a group. So, there's always these interesting things around data and perspectives that we can share. Yes, Andrea, I see your hand is up.
Yeah, thank you. And thanks, Dan, for sharing this data. I think your point, Farhan, about reframing it, to on-demand contraception is a great one, much as I also think we should really go strive to talk about sexual and reproductive health as opposed to family planning, again, for the purposes of youth and many other populations. I'm also, we often get really focused on the data, right? And there's a lot of good questions and conversation in the chat about the data itself. But then I always think when I see this sort of data, Dan, like what are we all thinking from a market standpoint, and the fact that so many people are going to the private sector and buying on-demand contraception, and we think about the cost of it, and what are the opportunities then for demand generation to just ensure that the buyers have a sense of their broader option set, right? That might be more cost effective or convenient in the long run. So I always think about on-demand contraception as like a gateway to maybe other product solutions as well. So I just kind of wanted to pose that to the group, and interested for any comments on that. And then I see Lester and Ashley have their hands up. So maybe over to Lester, and Farhan, then back to you to continue facilitating. Thanks. Lester, over to you.
Lester, if you are speaking, we can't hear you. Perhaps you might be on mute. I see that maybe Lester has dropped off. Andrea, I don't see.
Yeah, maybe shall we go to Ashley and then
Yes.
Lester will rejoin. Ashley, over to you.
Thanks. I just wanted to follow up on the point about the need for on-demand contraceptive pills. And in case anyone in the group hasn't gotten the latest information about the work to try to relabel emergency contraceptive pills, the 1.5 milligram LNG pills, we're trying to relabel them for on-demand use. That's not only for emergencies and potentially up to 6 times per month. And there's some evidence in support of this, like the Feston et al. Paper, but the Plan A project ran up against a regulatory dead end in Kenya and Ghana. And so the donors who are investing in this consulted with the EMA, the European Medicines Authority, and found that they will need to conduct a clinical trial to study the safety and effectiveness of repeat use within a month, up to potentially 6 times. So that study is, I think, just now getting funded and started, and it might be a couple of years before there's an actual label change to support that. However, there's enough evidence out there that we can be confident that at least a few times per month is likely fine, or just taking away some of that stigma in terms of withholding the pill from people when they come to pharmacies a couple of times in a year, or making sure that we are presenting it as something that can be used even if it's more frequent than the rare emergency that it's currently pitched as being suited for.
Thank you for that, Ashley. Very interesting, relevant, and we hope we get to discuss at some point those results from this study. Cindy, I see your hand up as well.
Sure. Good morning. Yeah, just a quick comment following up. Dan, thank you so much for highlighting this. I think this is a really interesting trend, as you said, that we've seen for several years now and in many different markets. And Andrea, I think your question is exactly the right one. So what does this mean in terms of market opportunities? And I think on one hand, Dan, you mentioned 48% of private sector spend. Not exactly sure what you mean there, but we just supported the Ministry of Health in Malawi and looking at different trends across methods. And like you've demonstrated here, emergency contraceptives in the last 6 years increased by over 600%. And I think the opportunity is that most of that product is being provided by the commercial sector. So it's private product that's being imported, paid for, distributed and sold directly by commercial distributors. So something like 70–80% of the market is private sector product. So on one hand, a huge potential, a huge opportunity for looking at how do we partner with those pharmaceutical importers and distributors. And then on the other hand, how are we making sure that clients are getting the information that they need at the pharmacy and being able to choose perhaps another method the next time around, or just making sure that they're getting access to that, to the full information. So that was my comment. Over.
Thanks a lot, Cindy. Then if you can quickly respond, I think we should then move to the next thematic area.
Yeah, thanks. I mean, I think this value for money piece is really where a lot of the discussion needs to be had, because if we look at the prices that the medications are being sold at, the price of the on-demand levonorgestrel 1.5 is pretty close to 3-month injectable. So you're getting 1/20th of a CYP for the same cost as a quarter. So trying to change consumer and provider behavior in that direction. This graph here is effectively taking the price to patient for all of those packs of emergency contraception and then scaling it up to a total value in millions of dollars. So this is about $20 million being spent currently by private consumers on EC. On-demand levonorgestrel. So The other thing is we're really interested as an organization in trying to create incentives for bundling of EC with, sorry, I've got to get used to this, with HIV self-tests is the other thing.
Okay, thank you for that, Dan. I think, as I mentioned, in the interest of time, we'll move on to the next thematic area, and I feel that somehow also relates to the question that Soumya has just put on the chat. And I'd like to invite Cindy. Cindy, you had a question last time around stewardship. So, any thoughts that you have so far on that? If you can start us off, and then we'll take the conversation from there. And as I mentioned, I think, somewhere the question that Soumya has just put in the chat around incentives for manufacturers, for example, is also, I think, quite closely related to this thought process around stewardship. So welcome, Cindy.
Great. So good morning, good afternoon, everybody. So the question that I posed in last month's session, based on the breadth and depth of very interesting private sector initiatives that are underway in Tanzania, I asked, so how is the Ministry of Health doing in its stewardship role and identifying and understanding the opportunities for strategic private sector engagement? And in health in particular, I think there's pretty widespread acknowledgement, acceptance that strong stewardship is critical to having a healthy, sustainable, mixed healthcare system. So being able to articulate what that strong stewardship looks like and then supporting ministries to strengthen their stewardship role is also pretty critical. So maybe just to briefly frame the discussion for Tanzania, it would be good to talk for just a minute about what strong stewardship actually looks like. And much of the literature discusses 6 key stewardship functions. And a couple of years ago, Palladium sponsored or collaborated with the Journal for Public Administration and Development on a special issue for stewardship and health system strengthening. And one of the articles that we wrote functions on trying to translate what those stewardship functions mean in terms of private sector engagement and in terms of reproductive stewardship of reproductive health and family planning markets. And I think what we found is that some of those functions are more commonly practiced than others. And so I would say some of the more common or more basic stewardship functions include things like generating intelligence. So obviously Dan's presentation on data is totally relevant. And so how is the health market steward understanding the whole market picture, including, of course, the role of the private sector? And so understanding and utilizing the data that exists, understanding perhaps what information gaps also exist, and then using that information, using that to guide policy decisions. Another key function is formulating strategic policy directions. So is the Ministry of Health able to incorporate that big picture vision of what the private sector is doing? And so that often includes things like national policies that define specific roles and responsibilities for the private sector. So I think in many countries, we've seen things like national TMA strategies or public-private partnership strategies, or even health sector specific national plans that mention the role and responsibility of the private sector. Stephanie mentioned a couple of months back for the Nigeria IHP project, they've even gone so far as to support the state ministries of health in developing a costed private sector engagement strategy. So really helping the ministry understand what some of the key actions are going forward, who is going to lead those, and what are the costs associated with them. And then another sort of basic or early stewardship function is also around engaging public-private dialogue. So are ministries of health comfortable with, and do they know how to engage in that public-private dialogue? And do some of the ongoing platforms and partnerships exist? And I think in Tanzania, there are a few different mechanisms, platforms, technical working groups where different sectors are meeting regularly to talk about private sector engagement. And then also, are there new efforts to bring in new private sector actors as well? In terms of some of the more, what I would call advanced stewardship functions that we tend to see less of, are things like addressing critical market barriers for private sector engagement. And Ashley Jackson mentioned last week or last month in some of the comments about the issue of product leakage. And she and I had a subsequent conversation about, how critical that is in terms of influencing the growth of the private sector health markets. But other things like being able to streamline registration and licensing procedures for the private sector, or access to training for private sector providers, or harmonizing and streamlining reporting requirements. So those are all examples of how the ministries could be proactive in terms of addressing some of these practical market barriers or even just bottlenecks. Another function is aligning policy objectives and national strategies to actual market interventions. So understanding how those multiple private sector initiatives that are currently ongoing, let's say in Tanzania specifically, how do they align to the ministry's goals and to what they are trying to achieve? And then finally, accountability and transparency. So is the ministry leading regular review sessions? Are they doing impact evaluations? Are they understanding how different initiatives and partners are contributing and performing over time? So those are just some thoughts to kind of kick off the discussion, and I invite others to comment and perhaps discuss where they feel the Ministry of Health in Tanzania is being particularly effective in their stewardship role, or perhaps where there might be some weaknesses. Thank you, Farhan.
Thanks a lot, Cindy. I think that was very insightful in terms of, and I know, the question around stewardship has been, an interesting one, in thinking about all of these different functions that you mentioned. But I think also in terms of who should be the steward more specifically, right? Is it the Ministry of Health? Is it a specific unit within the Ministry of Health? Should the steward be public sector? Does that bring about some kind of conflict of interest, especially in countries where the public sector has a certain amount of, let's say, high involvement or dominance in terms of programming? Should it be co-stewardship between a public sector entity and a private sector entity? Should there be different stewards for different environments? I know, I often feel like stewardship is one of those things where the thoughts will keep on evolving as time goes, but we may not necessarily have a very direct answer in saying that this is the steward or this is what they're supposed to do. But those are just my thoughts. Anyone else want to contribute to some of the things that Cindy has mentioned? Douglas, yes, I see your hand up.
Yeah, thank you for this. I found this really helpful overview, and I wanted to suggest that this kind of work, it might be helpful to link it to efforts. It's not necessarily intuitive, but to efforts to engage governments on domestic financing, and especially around family planning commodities, because as these sort of MOUs and country compacts are developed, there's a tendency to try to, which I think is important, to try to cost out need over subsequent years. And that I think crystallizes to not just ministries of health but ministries of finance, the acknowledgement that the cost of need of contraception is sort of perpetually growing as a function of population, as a function of growing CPR rate, as a function of inflation in the commodity markets, especially in local currency terms. And the only way to really address that growing cost is to look at policies regarding market stewardship, regarding the role of the private commercial sector. And so I think that then yields a desire on the part of government to engage in this question in a way that hasn't necessarily happened through direct advocacy. So I just think it's important that we link up these sort of market stewardship conversations to that discussion around domestic financing.
Thank you for that, Douglas. Cindy, I see your hand up. You want to respond to that?
Yeah, I think it's a really important point, and I think it's interesting. If we look back at the literature, a lot of the discussion around contraceptive security and helping governments plan for the procurement and for gradually phasing out of commodities is actually one of the precursors to the discussion around a total market approach and getting governments to understand what the costs are and to transition in that direction. So I think they're definitely complementary. So thank you for raising that point, Douglas.
Thank you both. And I think, just to add another, and this again takes me back to the comment that, Soumya made earlier. I think especially when we're talking about African countries, with currently the conversation around local manufacturing, for example, becoming quite big, I think somewhere, we also need to think specifically about how is the government being a steward in that particular aspect and, creating the kinds of incentives or the policies and the enabling environment to promote local manufacturing of, contraceptives in Africa, which would also then subsequently play a role in access as well. Any other thoughts? Sean, I see your comment here. Do you want to, expand on it a little bit as well?
Yeah, just the language that WHO has been putting out more recently, starting with its private sector engagement strategy, is focused more on this 6 governance behaviors, and I've been seeing and hearing them talk more and more about the governance behaviors and less about stewardship, and that using that stewardship terminology. And so it's been one thing that on some of the work we're doing on LHSS, the Local Health System Sustainability Project, we're trying to do our own internal alignment of what that means coming from a governance perspective, and how does the old language and the stewardship functions that Cindy was walking through, that everyone is familiar with and everyone knows, how does that align with this new language that WHO is promoting and putting out there, and how do we kind of make them speak to each other? But I think it would be really interesting for this group to have that discussion as well, and maybe we can bring in some of the people from the team that worked on that strategy to engage in that discussion with us, because I do think it's something that's been hard for a challenge or interesting for us to try and just kind of wrap our heads around, and I think getting the whole community on board would be, or involved in that discussion would be a good value add.
Yeah, I agree
Thank
with
you
you,
for that.
Sean. And
Yeah,
the other
sure,
thing that
go
I
ahead.
would add is, and one of the things that we tried to do in the journal article that I talked about was even trying to translate, what those behaviors, so you can call it a function or behaviors, but what does that really mean in concrete terms, and helping people to understand that, I think, is a big part of the discussion and what needs to happen moving forward.
Thank you for that, Cindy. And I think, as facilitator for this particular group, and Andrea, I'd love to hear your thoughts on this. Is I think, one of the things that I'm seeing is, as much as we've wanted to sort of have a country focus, and but I think perhaps for some of the sessions, as Sean put out as a suggestion, perhaps we could pick some of these thematic areas and try to see how we can think about these particular areas as it pertains to the private sector market in family planning and in sexual and reproductive health. So that's also, something for us to think about, especially seeing all the interest that there is in certain topics, for example, stewardship.
Yeah, thank you, Farhan. And I'll just jump in here to say also thanks, Cindy, and thanks, Sean, for these points in particular. And Sean, I can assure you that this is something that we're actively thinking about within FHM Engage. And to Farhan's point exactly, I see a lot of value of somehow us achieving this intersection of these sort of conceptual topics with the country-based orientation, because it's really where the rubber meets the road, right? And I know that Cindy was doing her best to kind of raise these questions about stewardship in the context of Tanzania. So maybe there's a way that we can sort of proactively insert some of these concepts that we're all trying to work on as we talk about the individual countries, as well as potentially doing spin-off meetings or conversations, or even the idea of if a small subgroup wants to come together to write a blog or a brief across projects too. So that's very much part of what we want to facilitate out of this, and make this community be what works for everyone here. So I guess that's where I would leave it at this moment, Farhan.
Okay, thank you, Andrea. And I think to respond to some of the things that Cindy brought up, I think, just to again close this loop and move to another thematic area in the interest of time, is that, as I mentioned last time, I think, in terms of the programs that we work with in Tanzania, the reproductive and child health section or unit, which, under which the family planning work happens, and we have a family planning coordinator. I think that program is actually much more, I would say, private sector friendly, and thinking about the private sector quite a bit more. I think over the years, there's been a lot of work that has, happened continuously. I mean, with Shops Plus, and then now with FHM Engage, there's a lot of thought going into bringing the private sector to the table, which a lot of it has already been done. I mean, many of the technical working groups, especially those that pertain to family planning, have private sector attendees. They are inviting the private sector. They are asking for data from the private sector. I think, the next sort of frontier is to figure out how is that being valuable, especially so for the private sector, and this question around incentives, right? Because I think in Tanzania, where the public sector is quite involved in a lot of the things, whenever they ask the private sector to, let's say, attend a meeting, the private sector will come there, they will share the data, they will cooperate. But then, is that valuable to the private sector? Is that really helping them grow? Are their concerns actually being listened to? I think that's actually the work that we are currently doing. So I would say that the willingness of stewardship is definitely there. The willingness to engage the private sector is definitely there. It's the operationalization of that is something that is a work in progress. So I'll respond to that, because I know there were some questions you asked around stewardship within the within the within your narrative. Yosh, I see your comment, and yes, I think these are thought processes that will definitely have to continue, and it's great to see the amount of discussions that we've had on the session today. Moving on to the next thematic area that we had identified, I would like to invite Ashley Jackson to, there was a question she had posed around product leakage, and I'm very happy to see that there were discussions post that with Cindy. So Ashley, what would you like to start us off on that discussion?
Yes, thanks. I would be very interested in talking about this topic for Tanzania or examples of other countries. The topic is leakage or diversion of contraceptive products from the public to the private sector. And private sector actors, as well as ministries of health, have flagged this as a significant concern in many countries. So to explain what I'm talking about, I just put this in the chat as well, but this is an example that was published in Global Health Science and Practice. We know USAID and UNFPA donate certain brands of oral contraceptives, and I'm just using OC pills as an example, but this also, we've heard, happens with injectables and other products. So these brands are meant for free distribution in the public sector, but in Angola, 77% of retail outlets were selling one of these brands in the private sector, in spite of the intent to sell them to distribute them for free in the public sector. And because these brands offer the lowest price to consumers when sold illegally in the private sector, they're competing against commercial brands or socially marketed brands that have an approach to try to move toward more financial sustainability, and that leaves little space in the market for other brands to grow. So my questions are, I'd love to just better understand the situation and understand what we might be able to do about it. I'm wondering if others have data, including from Tanzania, around how common leakage is, where it's most prevalent, which channels. We hear sometimes about the private sector providers in countries such as Uganda even being arrested and sent to prison, implying that it was the provider themselves who leaked the product, or is this happening at a different stage in the supply chain? Is it more so in the pharmacies, drug shops, or clinics? And we hear about products crossing borders, such as coming from Uganda into Kenya. How common is that actually? Is this anecdotal, or is this a major phenomenon, such as we saw in that survey in Uganda? I'm sorry, that survey in Angola. And then is it happening so much with other products outside of the FP space, or products that receive less donor subsidy? And then what can we do to address the situation? We've heard about ministries of health trying very hard to regulate and monitor what is being sold in the private sector, but it's really challenging to do with resource constraints. And so, are there other approaches you all have heard about that work? And then if Michelle Weinberger or others who do data analytics are still on the line, I'm also wondering about what this means for our national level data about how common it is for people to access unsubsidized products through the private sector. So I'm thinking about the LEAP report and even looking at data from Tanzania. Now, I don't know how common leakage is in Tanzania, but the LEAP report that RHSC published says that in Tanzania, 39% of OCP users and 30% of injectable users get quote unquote unsubsidized product from the private sector. And that is not the socially marketed products. But is this truly unsubsidized, or are we thinking that a very high percentage of it could actually be a leaked product from the public sector, which then kind of throws into question our whole view of how, whether the private sector markets for FP are thriving for OC pills, for example. It's a whole lot of questions. I'm curious if anybody wants to weigh in on any of them. Oh, and I see Dan chatted that if there are different brands in the public and private sectors, we can see these sales in our facility data. If the brand is available in both, we can't help, unfortunately. It needs to be a different brand, not a different pack, based on the way it's recorded. That's a great distinction, because we do hear sometimes about, like in South Africa, Jadel having a not for retail sale label or for government use label, but it's the same brand in both cases. Michelle.
Yeah, I can jump in on the LEAP point. I mean, I think to the extent that LEAP is able to capture that subsidy, right? Essentially what we're doing is we're saying, how big do we think the private pill market is in volume? And that is our denominator. And then we're putting in our numerator all of the data that we can collate together about private sector, private subsidized sales volumes, right? So that's coming from DKT social marketing statistics and some other sources. So inherent in that, we would miss leaked products and we might miss other kind of subsidized products that we're not really able to easily capture those volumes. We have been doing some work under NPHD to use data from the FP Watch surveys, which the data is a bit outdated, but they are surveys PSI conducted a couple years ago that did full retail audits that captured very detailed data on brand and volume and price. And from that, we're able to do some looking at what it's not explicitly leakage, right? But we could see kind of public sector brands and private sector, or we could see products in the private sector for which the retailers did not pay for them or paid very little prices for them. And so we've been having some discussions around that report of like how do we frame that in getting that more in-depth view. So maybe that's some work we could come back and share with this group at some point. I don't think it fully gets at that issue, but maybe is another step closer.
That's super exciting, Michelle. I just had the thought the other day that we should go back to FP Watch to look at the data there. And I'm so glad someone's doing it. Dan, your hand is up too.
Yeah, I was just going to come in quickly on this point around the proportion of the market, the private market, that's this unsubsidized product. I've been looking at export records out of India, Indonesia, Pakistan, Bangladesh, Hungary, a few other countries, and import records as well. The impression that I'm getting is that there is, this work is being funded by SEMA, but it's probably too early for me to give you any like proper conclusions at this stage. I do think that it's slightly showing that the size of the unsubsidized private market is smaller than I'm seeing in things like the commodity gap analysis. Like the amount of product actually being brought in by private wholesalers does not seem to be in line with those estimates. But then it's possible that they're being brought in by SMOs just without subsidy, because I mean how the finances work in this space is very murky in terms of like being able to split out what's true private sector and what's subsidized.
Also, just to add, there's like a lot of other assumptions, right? As you were talking about in your presentation, Dan, around like converting between volume of product and users. So I think I'd be happy to talk more offline about it, but I think there's lots of noise in comparing these different types of data sets. And so there's also likely discrepancies kind of just inherent to trying to put apples and oranges together.
Yeah, and I see Megan Christafield also chatted about governments not wanting to allow private sector provision of DMPA SC. We're facing the exact same issue in what I think is a different country, multiple countries actually. But I can tell you it's Uganda, and the Ministry of Health is very clear about you have to have a different brand to enable sales of the product in the private sector. You can give free product out through the private sector if you want and charge a service fee. But if you want to actually charge for the units of the product itself, which of course is necessary to really have a functional private sector market for the product, that they're saying is not allowed until there's a separate brand. So we're working on trying to figure that out. But you know, when we bring that then into other conversations, we sometimes get questions like, well, is this not a problem for other products? There are lots of products outside of the FP space where the same brand is sold in the private sector and given for free in the public sector. So how have they managed it outside of the FP space?
Thank you, everyone. I see some, again, actually lots of questions. I think, again, in the interest of time, just to round this off, what I will say is that, okay, Cindy, do you want to go?
Sorry, Farhan. I just
No
thought
worries.
maybe to wrap up, since we talked about stewardship and governance previously, one of the things that Ashley and I talked about in our call is, from a stewardship perspective, this is not an easy issue to resolve, and it doesn't only usually involve a single agency, a single government agency. So it's not only the Ministry of Health, it's the medical supply stores, it's the and even in sometimes legal and justice sectors of government. So it is, I just wanted to sort of link it back to the previous conversation. This is an example of one of the market barrier issues that is quite complex and seems difficult to address and really does require strong political will and strong stewardship or governance. Over.
Thank you, Cindy. And Ashley, I think, I'll just add that, having been in this space in Tanzania for quite some time now, this has never been, highlighted as an issue, not that I have heard of, and I'm quite sure there aren't a lot of like papers and all that on this. Again, you ask about other commodities. I do know, for example, with the HIV STK rollout that we are currently doing in country, and I think this relates to something that Dan mentioned, right? That currently, for example, if we talk of HIV STK, we have, one product or a short that is both in the public sector and then through certain pilots in the private sector as well. And so there has been report of leakage and all of that, and there were some of these measures that we are talking about, barcoding, etc. For family planning, I don't think that has ever been highlighted as an issue, and I think it's great that you bring it up. It's an interesting thing. I do know, for example, one of the things that the reproductive and child health section is working on is developing their own research agenda for the next few years. So perhaps this can be something that can be, submitted to be added within that research agenda, so that we are keeping an eye out for this as well, definitely. But I would say, having been in the space for quite some time now, I've never heard of this being highlighted as an issue.
Thanks so much for the fascinating and helpful conversation.
Okay, thank you so much. And so again, in the interest of time, let's move on to our last thematic session, which was actually, brought up in some of the previous themes as well. And that is around, challenges related to financing. So Mariam, do you want to, introduce the theme?
Hi, I was on mute. Hi, yes, thank you so much. So yeah, I think a lot of these themes have already been brought up. But to give some context, Social Finance, where I work, is a nonprofit that does impact investing and advisory work across a variety of issue areas. And we are currently working with USAID to really help them understand what some of the current business challenges are that existing local businesses that provide contraceptives face across the value chain in lower middle income countries. And we are trying to understand also if different forms of finance and technical assistance can be used to address some of these challenges and promote expansion of contraceptive services. Currently, we're still in the beginning stages of our work, but currently we have seen that in the value chain, obviously with manufacturing and procurement, a lot of global agencies lead that work. And the local businesses, we see that more in the dispensing and distribution aspect of the value chain. And so we are really trying to understand from that local perspective, what are some of the specific business challenges that these SMEs are facing? And are there any innovative financing structures that we could create to solve any of these problems? So it is just kind of a way to structure the conversation and pose it to everyone on this meeting right now to see what they have specifically seen, and if they've seen any kind of innovative solutions that we can like look a bit more deeper into. Obviously understand that's quite a large question that I'm posing, but would love to start there and can kind of continue from there on.
Thank you for that, Mariam. Does anyone have anything to say, any response? I think, Mariam, while people are gathering their thoughts, I will chime into this because I think this is also an area of, personal interest and some of, the work again that we are trying to just understand a little bit more of in country in Tanzania as well, because we have a very sort of booming, I would say, startup, ecosystem. There's a lot of conversations happening around, startups in health especially, but then I don't think we see any particularly in the space of, let's say, sexual and reproductive health, in the space of family planning, and especially if you're talking more so in the products and services. A lot of the startups that we have are probably doing, something digital, providing a data related solution, some kind of awareness, counseling, etc. And so that is what we are seeing in country. In terms of, again, opportunities for finance. So for example, as FHM Engage, again, we are working on the finance from the financial institutions part, working with financial institutions to try and develop health related products. But again, those are not family planning or reproductive health specific, right? Because the banks are looking at the health sector more broadly. We are also exploring, so we have certain initiatives in country that are funded by different agencies. For example, one is called the Funguo program, which deals with startups. Again, they work across different sectors. Health is one of them. But again, within that also, I don't think there's any focus on sexual and reproductive health, family planning, etc. So Tanzania is quite interesting as a space to think about this and to have conversations around this in terms of, and maybe we can have again a conversation offline regarding this. But there is a lot of movement in terms of creating an ecosystem generally for startups in terms of training and capacity building, in terms of financing, and really looking at it even from a blended financing point of view, so that it's not just one aspect of financing. Anyone else want to give their thoughts to this? Yes, Sayaka.
Hi, I hope everybody can hear me.
Yes.
This is Sayaka Koseki from Palladium. I was just wondering, Maureen, if you've already, in what phase you are in this process, if you've already been gathering a bunch of resources, or if you're soliciting information around this, just to give context. For example, under the Health Policy Plus project that wrapped up and continues under the new Propel Health project, we have looked at blended finance options for family planning. So there's literature there that I think we can be sharing with you. Similarly, for the commodities team for USAID, we have looked at specifically in India some of the policy barriers to investments, especially looking at the supply chain players in family planning. So there might be some resources there just in case that hasn't come past you yet. And also, this is a little bit dated, but speaking to kind of supporting social enterprises working in the FP space, I think of our work that we did under Spring, where we supported a number of social enterprises impacting women and girls, and there were a number of entities that were working in this space. Like Kasha, for example. So just wondering if any of these things might resonate for you.
Thank you. Yeah, that would be super helpful. I think I've read some of the Spring work and the case studies of Kasha, but the first Health Policy Plus project, that would be super helpful. We are kind of in the stages where we finished our initial literature review and expert interviews and are starting to look at how we can kind of get primary interviews with SMEs to really understand it from their experiences on the ground at the local level. in countries. But obviously would like still really, that'd be really helpful. So I can follow up with you offline on that. This is a slightly, sorry.
Oh, go ahead. Sorry.
I was gonna say, this is a slightly different question. But obviously I feel like in this space, we're seeing the social enterprises and kind of like startup space. And then we see the local businesses such as pharmacies and like local pharmacies. And I think looking at how to provide support to both of these types of enterprises are obviously important. But I'm wondering in people's experiences, where they see like more impact could potentially be driven from, because I sometimes feel like the social enterprise space could feel very fun and innovative and like cool, but is it actually something that we are going to see scale and like impact, or should we really be focusing on the businesses that are really deep, really rooted in the local communities as is? And would love to get people's thoughts on that.
I mean, I think, Mariam, if again I can chime into that, perhaps, and we have a very good example of that in Tanzania, actually. And if you are looking to speak to, social enterprises or businesses, then we can definitely share that example. They're called, Dawa Mkononi, which means, medicines in your hand in Swahili. And so, what they have done is, so it actually started off as a pharmacy business, but then they have over time taken a social entrepreneurship angle to it. So they do have still a pharmacy arm, but I think what was interesting for us as we have engaged with them is that they have a very, their motto has always been, we don't want just to put the product in someone's hand, right? It's not just about giving someone medicine, it's about giving them value, both from a patient perspective, from a community perspective, etc. And they're doing some very interesting things and have grown quite a bit, over the years. And so happy to make that, connection as well when you want to. So I see a lot of discussions. I see a lot of, great connections happening, but I think in the interest of time, I'll have to, end it here. I am very happy to see that today there was a lot of resource sharing. There was a lot of potential for people to speak to each other. There was already a case study of Cindy and Ashley having worked together. So this is what, as Andrea mentioned earlier, this is the intention of this particular group. And we really hope that these conversations continue and that, sometime in the future, we can have, two people who met on this group come together and do a presentation of work that they ended up doing after being introduced within this particular group. So with that, I'll just say thank you to all participants. Andrea, you want to close us off?
Yeah, thank you, Farhan. Echoing everything that you said, and thank you for everyone's resource sharing with Miriam. Again, this is a great example. You'll be hearing from us about the April session. We're making some final decisions about how we're going to approach that, and we are going to keep reflecting on, as the points were raised during the call today, like, what about these things that come up that are maybe more topical and not applicable just to one country? So we're sorting through that and just keep everything coming. And thanks again to Kuyosh for kicking off with comments this morning. And we'll be hoping to have Ben Light back on the call starting next month. So with that, thank you. And a huge thank you to Farhan, of course.
Thank you for the opportunity. Let's all keep engaging and see you all next month.
Thanks, everyone.
Thank you.
Thank you, Farhan. Thank you, Andrea. Well done. I have to jump off to join another call, Farhan, but lots of great comments from the chat as well. Let me know if you see anything that you would like to follow up. All right, maybe Farhan is gone.